see the slide. Yes.
Okay, good.
I have started the recording. So I think you two have met earlier in Kochi during
Kochi,
ISRS
yes,
workshop.
yes,
Yes,
yes, yes.
I think so.
In
Yes.
Kochi.
Yeah.
It was a nice place.
Yeah.
Yeah.
2019 is, wasn't it?
No, sir, it was 23. 19
Sorry,
was
23, yes.
ISSFN meeting. 23 was ISRS education course.
Yes, yes, I remember now. Yes.
Mm.
Dev Narayan Datta had hosted it.
Exactly.
Mm.
Recently, sir has hosted Devnarayan.
Wow. Nice, nice. But he's moved, right? Dev is now no longer in Kochi.
Yeah, he has moved to Hyderabad, so probably Yashoda.
Yep.
So it's already 5:30. I think we should start now.
Mhm.
So good evening, everyone, and thank you so much for joining. And this is the fourth radiosurgery webinar today. And the topic is very relevant because there are so many competitive machines and the technology in the market that it's no more just a zone of the frame-based radiosurgery. And that's why we have a very eminent speaker and a person who has an experience, a first-hand experience on both the machines. So I request my co-chair, Professor Salzuk Pecker, to introduce our speaker today. Professor Pecker.
Thank you, Manjul. Hello, everyone. Today, our guest is Dr. Aditya Gupta, and we are very glad to have him for this presentation. Dr. Aditya Gupta is an esteemed and highly accomplished neurosurgeon in India, serving as the chairperson of neurosurgery, CNS radiosurgery, and co-chief of the Cyberknife Center at the Artemis Center at Artemis Hospitals, Gurgaon, and he's graduated from the All India Institute of Medical Sciences, AIIMS, New Delhi, and also served as an associate professor of neurosurgery until 2009. And following this, Dr. Gupta co-founded the Institute of Neurosciences at Medanta Hospital, Gurgaon, and now he's working as an additional director of neurosurgery until 2016. And sorry, Dr. Gupta completed his advanced training from renowned international institutions, including the universities in Amsterdam, Paris, Marseille, Kiel, and Wake Forest University in United States. And he did fellowship in the medical center in Richmond, Virginia, USA. And Dr. Gupta is an experienced neurosurgeon who specializes in stereotactic and functional surgery, including radiosurgery, DBS surgery, epilepsy surgery, and neuro-oncology. He has served in academic positions and was the immediate past president of the Indian Society for Stereotactic and Functional Surgery. He has also served as a board member of WSSFN. Dr. Gupta, thank you very much for accepting our invitation for this presentation. And now we are ready to listen to you about frame-based versus frameless stereotactic radiosurgery. So I leave the stage to Dr. Manjul. Please, Manjul.
Thank you, sir. Thank you for introducing our speaker. Dr. Aditya, I request you to share your slides.
Yes. First of all, thank you, Manjul and Professor Pecker, for your kind invitation. It's a huge pleasure for me to be here, and I'm sharing my screen. I hope my slides are visible.
Yes, sir.
Perfect. So this is a very interesting topic, I think, and something which is very hotly debated. And what I would like to start by saying is I have no disclosures, and I'm actually not a radiation oncologist or a medical physicist. So I have a very practical take on things. And I've been fortunate to work in institutions where I had access to several versions of the Gamma knife for quite some time. And I did some work on the Synergius using a frame in between when I was not working on the Gamma knife, and I got a cyber knife from 2013 onwards. And I have some experience with using that now for the past 13 years. So what I'll do is I'll quickly revisit some key principles, and that always helps to put things in perspectives. Then I will go to both the approaches, frame-based versus frameless, the workflow and the planning a little bit. Then we'll go to the comparison of frame-based versus frameless and the indications. And finally, we'll have a zoomed out view and the current scenario and what do we learn from all this. So as all of us have seen this very famous slide, this is Professor Lars Lexell's first publication in 1951. And that really set the stage for this exciting field. And basically, this is not radiotherapy. Radiotherapy and stereotactic radiosurgery are very, very different because we want to treat very small volumes, but with a very high dose per fraction. And the structure that we aim at has to be very, very well defined. And of course, the selection of the particular indications is also very critical. So for colleagues who are still thinking that, radiotherapy and radiosurgery is, well, more or less the same thing, radiosurgery is very different in terms of the intent, the dose fall off, the internal dose homogeneity, and interestingly, radiosensitivity is not very, very important. So as I said, we treat smaller volumes. We give a very high dose per fraction. For example, in lesioning with the gamma knife, we would typically use a Dmax of 120 gray compared to 1.5, 1.8, or 2 grays per fraction in conventional fractionated radiotherapy. And we have a large number of unique beams that are used in these treatments, and it has to be very, very highly accurate. So this is also what I have shown in this slide. And really, if we call something as radiosurgery or stereotactic radiosurgery, several of these conditions have to be met for the procedure to be called as a stereotactic radiosurgery procedure, which otherwise then blends very easily into SRT or IGRT or IMRT and so on. Now, the essential thing is that we want to target and ablate a tumor with a very high lethal dose, and it is, of course, lying in close contact with the brain tissue, which has to be saved. And not just the brain tissue, very, very frequently, there are critical structures which are extremely radiation sensitive. So how do we do that? It's actually very simple. On the left side is the simplest form of radiation therapy, which used to be called as parallel opposed fields. That is how radiation therapy began. And then you have the concept of cross-firing at the tumor from many, many directions to reduce the dose to the normal tissue and build up a lethal dose inside the tumor. The first important thing is that whenever we want to do that, we have to have stereotactic accuracy. And from neurosurgical standards, we know that stereotactic accuracy means an end-to-end accuracy of about a millimeter. And this is exactly what serves as the standard for stereotactic radiosurgery as well. And how radiosurgery began is by this very simple principle that each point of radiation delivery has to have precisely delineated coordinates. And not only that, the imaging and treatment space has to be accurately and reproducibly co-registered in space. So the second very important aspect is the selectivity of the radiation delivery. In what I mean is predominantly the sharp fall off, and also something which we will discuss in some time is the conformity. Now, the selectivity being the key technical principle depends on a number of parameters. And for example, it depends on the beam energy of, let's say, electrons from the cobalt source in gamma knife is very different from a 6 megavolt or a 10 megavolt linear accelerator. And in these different platforms, the source access distance is also different. So platforms with a high SAD, such as the LINAC and the CyberKnife, have more dispersion than the low SAD platforms for example, like the gamma knife and the ZAP. Now, the beauty of radiosurgery is that you can deliver a very high dose of radiation with a very, very sharp fall-off. So one of my very old examples, which I like to show, is from 2003 using the Model B Lexel gamma knife, in which for a prolactinoma, I could theoretically shoot at 40 gray margin dose, and no part of the visual pathway would even receive 10 grays. So we come to the two approaches to radiosurgery, which we are discussing today. Essentially, the frame-based that is how it began, vis-a-vis the frameless. Now, frame-based intrinsically is based on rigid head frame immobilization, and the rigid head frame immobilization allows stereotactic imaging with fiducials, and the same head frame docks with a mechanically defined isocenter in the treatment system, the gamma knife being the oldest and the most classic and the most well-studied example. And the treatment spaces are both true stereotactic coordinate systems, both the imaging space and the treatment delivery space. Now, Frameless is an innovation in which we do an imaging co-registration between the delivery space and the imaging space. And in fact, this is in line with the frameless neuronavigation revolution which we are well aware of in neurosurgery. Now, in frameless radiosurgery, what is very important is onboard imaging to verify and maintain the position of the patient. So how that is done is by two methods, rather three methods. One is using onboard X-rays, which is the classic example being CyberKnife and ZapX, or you could do a cone beam CT on board, such as you have in many of the linear accelerators and also in the gamma knife icon, or you could use an optical imaging, which is also, for example, available in the gamma knife icon. Now, frameless, basically the problem that you come across in frameless is the intrafraction motion of the patient. So as I said, it's very important to have frequent imaging to detect that and to correct that. So frequent stereoscopic high resolution X-rays or cone beam CT, which can be done frequently, and they can even be done during dose delivery, are very, very important for modern, accurate, frameless radiosurgery. So couple of pictures to show you the evolution, the first gamma knife, and interestingly, as you see, that time the physicist would do a lot of calculations on paper. Then the further models of the gamma knife enabled sort of very, very accurate radiosurgery to be done. And as we know, the basic mechanism of gamma knife is to keep the lesion at the isocenter of these 201 beams, which focus at that point very accurately. And of course, you can have different size collimators, which are seen on the right side, to produce beams of different sizes. And the set of beam delivery, which is focused on one point, is in gamma knife terminology is known as a shot. So perfection was the next evolution in which each shot could be composed of more than one kind of collimators. So you could have an irregular shaped shot rather than a spherical one. At the same time, LINAC radiosurgery started getting popular in many parts of the world. And in LINAC, what you have is basically a set of non-coplanar arcs that can also produce a very, very high dose at the target area and a very, very rapid fall off of the dose. CyberKnife is an advancement of the LINAC principle in the sense that the LINAC moves around the patient and is not limited to arcs. The compact LINAC can actually deliver multiple beams by moving around the patient in numerous angles. And this is one of the current versions of the CyberKnife. Now, ZAP is the latest entrant in the field, and this is again very, very elegant technology in which the entire system is self-shielded. And what you see here, the LINAC is a LINAC which is gyroscopically mounted, and it can work on dual planes. So therefore, it can achieve very, very elegant and highly conformal dose distributions with a very steep gradient. And of course, similar to the CyberKnife concept, you have the stereoscopic X-ray imaging and the detectors, which help to maintain the position of the patient accurately. And finally, you have the Gamma Knife version, which enables completely frameless radiosurgery using a cone beam CT on board, along with optical imaging. Now, the question arises is, what is the need for frameless? As we saw, it began with the frame-based Gamma Knife, then the LINAC-based systems. The neurosurgeons and the radiation oncologists started working initially with the frame, then LINAC-based frameless, and now you have the Gamma Knife, which also has a completely frameless option available. I think the reasons are the wider availability of the LINAC technology. And as LINACs evolved with accurate onboard imaging, they enabled very accurate frameless radiosurgery to be done. The key advantage of frameless methodology is that it can be done multi-session. I think this is the single biggest reason and advantage for frameless radiosurgery to become so popular. And of course, from intracranial work, it has spread very nicely to extracranial work, including neurosurgical work on the spine. It has frameless radiosurgery provides more comfort. And as I said, it is part of the same evolution which we see in neurosurgery, which was the evolution of frameless stereotaxy. So somewhat similar, the SRS milestones, the evolution of technology, starting from the first Gamma Knife, then to the first LINAC, then to the first Cyber Knife, then different versions of the Gamma Knife, then the ZapX, and then the Icon. Now, to summarize the workflow, the first step is typically target imaging or the imaging which is carried out for planning purposes. So what happens is that in a typical frame-based Gamma Knife procedure, the first step is to place the frame. Then we do the target or the target imaging, and then of course the planning and the treatment delivery. Whereas in a frameless situation, what you would do first is the imaging for planning purposes. You would also create the mask. Then you would do the simulation imaging with which the system matches at the time of treatment delivery. Then you have the planning process. Once you have a good plan, then of course you have the pre-treatment verification, and then is the delivery of the treatment, which could be single or multi-session. Now, treatment planning systems essentially are of two types. One was there is still the forward planning option available, for example, in Gamma Knife, wherein you could place these shots in a target and manually adjust the position of these. But more and more, I think we are shifting to inverse planning because of the huge advances in computing technology, which really help us to create plans in a very, very short duration of time. So in inverse planning, which is, I think, the most popular right now, is that you just set the desired dose distribution and you set the constraints to the surrounding structures, and the treatment planning system will will develop a plan in a very short span of time, and you can evaluate competing plans for delivery, and you can treat the best plan which you find for a given patient. So this is example of a Gamma Knife treatment planning in which you have these spheroids of radiation which get packed into the target space, and they create a dose distribution which actually mirrors very nicely the outline of the tumor. And basically, now coming to the radiobiology very briefly, is that in single fraction SRS, what you have to treat are limited volumes because of the fear of the radiation adverse effects. And also, they have to have some separation from some very critical organs at risk. The most classic example being the visual pathway or the hypothalamus or even the brainstem. And we know that single session SRS has a unique radiobiology in the sense that apart from the DNA damage and the cell kill, the endothelial damage and the microvascular damage are the additional mechanisms which come into play anytime you are using more than 6 or 8 grays in a single session. Now, there is a size and dose limitation, which is very obvious from radiobiology. And this is a foundational trial which told us that what were the typical margin doses you could use for targets that were of a particular diameter. So in practical clinical experience, whenever you have larger volumes, typically more than 10 or 12 cubic centimeters, multi-session becomes a better strategy. And we have enough literature proof of that as a good um, strategy when you have these larger lesions. And there is a large body of literature attesting to the efficacy of this, for example, in meningiomas, acoustic schwannomas, and now even AVMs. In multi-session radiosurgery, larger volumes are possible, and the separation from critical OIRs is not that critical, because what you're doing is you are exploiting the repair capacity of the neural late responding tissue, which repair capacity does not exist in the tumor tissue. And multi-session radiosurgery is definitely not possible with a rigid frame. And the other thing is that using the linear quadratic model, one can easily sort of tailor the 3-session or a 5-session dose if you're aware of the alpha beta value of a particular target. And you can devise these kind of fractionation schedules, which are based on science and which are actually, they have a lot of evidence behind them as well. So to give you a very quick example, a classic situation of a pituitary adenoma, which is remaining after surgery, and this is still very, very close to the visual pathway. Now, the ablative dose for a pituitary adenoma would be definitely a minimum of 12 gray. In fact, most of the people would treat this with 15 grays as the margin dose. And the optic chiasma, which you'll see in very, very close proximity, has a single session tolerance of somewhere around 8 grays. So one simple method to do this is to use a 3-session radiosurgery in which you could easily deliver a Dmax of 18 grays to the visual pathway without a high chance of radiation-induced optic neuropathy. And 18 to 24 grays in 3 fraction for this tumor would be a lethal dose, and it would serve our purpose very well. So this is a very simple illustration of how a 3-session radiosurgery is able to take care of this rather difficult situation. Now, how do we compare frame-based and frameless radiosurgery? So let's begin by comparing on all these axes. So the accuracy, the quality of the plan, the workflow, the outcomes, and the indications. Now, immobilization accuracy is obviously highest in the frame-based, and really it's like pinning somebody down. So if you pin down using the frame, the interfraction motion is practically going to be 0. And I think which is a very, very valuable method of achieving accuracy with a very high dose of radiation in a single session. Having said that, frames are also prone to mechanical deformation after years of use. And in fact, if they are used improperly, then the deformation can happen very quickly. A suboptimally applied frame by somebody who's just beginning to learn this, or rarely a patient with an AVM who has a seizure with the frame on, could actually result in a frame displacement. Now, in Frameless, as I said, imaging is imperative because there are these different variables which could impact the position of the patient. One is the voluntary shifting or the micro adjustments, which are very common in patients who are conscious and lying on the couch for 20 minutes to 30 minutes to 40 minutes. Swallowing, respiratory head bobbing, coughing, and tremor are the other activities which could result in a intrafraction movement. A relaxation drift of 0.3 to 0.8 millimeters has been noted at 30 minutes. And in fact, if it is unchecked, unmonitored and unchecked and uncorrected, it could even reach 2.5 millimeters. The intrafraction motion is nearly eliminated by frame-based SRS, and this is probably the single most compelling reason to do that. But having said that, in a frameless situation, you have several elegant technologies which enable you to monitor, check, and even correct the movements. So the numbers of the typical errors which creep in are as mentioned on this slide. And you will notice here that the frame-based, for example, using the gamma knife or the LINAC, the interfraction translations are extremely low, but the modern frameless platforms which use a mask and which use high quality imaging and correction are reaching very, very close to the frame-based numbers. Now, the real measure of the error, the spatial accuracy and the error, is something called as a total system error, which is a root mean square of all the contributing errors. The gamma knife frame-based total system error is somewhere below 0.5 millimeters, whereas in a LINAC frame-based, the same error could be between 0.5 and a millimeter. As far as the CyberKnife is concerned, the total system error could be approximately around 0.6. And both the Gamma Knife icon, that is the frameless use, and the ZapX have again very, very similar total system errors. Now, it's important to note that the total system error does not just depend on the platform that you are using. It depends on a number of factors, including the imaging, the kind of immobilization as we've seen, but also the calibration, the delivery, and the QA. Now, there are several articles. So this is an article from Shankar's group, in which they showed that the enhancement, which is a well-studied phenomena after trigeminal radiosurgery for trigeminal neuralgia, the center of contrast enhancement has a very strong correlation with the Dmax, the point at which the maximum dose has gone. And analysis of this shows that the errors are really, even in the frameless treatments, are actually very, very low. Another few papers which show that the translational shifts in modern frameless stereotaxy are actually very, very low. So this is another study showing the same thing for trigeminal neuralgia radiosurgery. One publication which I contributed to when I was doing my LINAC frame-based work back in 2013 showed us that really between the frame-based and the frameless use of the linear accelerator, there was practically no difference in the positional accuracy. Now, the second is the quality of the plan. And this has been very nicely studied in a recent publication in 2023, And this is what is called as the benchmarking study by Paddock and his colleagues, in which a set of plans was earlier included in the 2016 study were restudied, replanned with the platforms which were selected as state of the art in 2022, which included the Gamma Knives Icon, the CyberKnife S7, BrainLab elements used in the Electa Versa ST or the variant TrueBeam, the variant Edge with HyperArc, and the ZapX. Now, to people who may not be entirely familiar with these metrics are very well studied mathematical formulae which tell us how well a plan is in terms of its intrinsic quality, in terms of the coverage of the target, selectivity, and something which is very important called the Paddock's conformity index, which is essentially the selectivity times the coverage. So I will not go into the details of these different metrics, but these are very, very important ways to judge the quality of a treatment plan that has been generated. And the findings of this very important study showed that all these modern platforms really have very small differences between them. The point worth noting was the high gradient index in Gamma Knife and Zap. So gradient index, the lower it is below 3, the better is the gradient. So we find ZapX actually has the best gradient index. And you will notice the CyberKnife has a very good conformity index, which is the PCI or the Paddock's conformity index, but so do the other technologies. So the key learnings from this very important study was that the modern systems have vastly improved with respect to the 2016 benchmarking study by the same group, and the differences have significantly narrowed. Now, different platforms have their different strengths, but there seems to be an inherent trade-off between the gradient and the conformity. So, for example, the Gamma Knife and the Zap had the best gradient index, and which is very easily understood because they are lower energy platforms, so the dispersion is less. And also, both these have a less source access distance. So these two factors combined produce a smaller penumbra. The CyberKnife and the HyperArc had the best Paddock conformity index. The Linux platforms, for example, were the fastest. So to give you an example, the HyperArc could treat 14 METs in 10 minutes, which is amazing. Overall, Gamma Knife had the best gradient index and the R50, so which automatically tells us that it is a very, very good platform for treating small lesions with a high dose, therefore the platform of choice for functional indications, whereas CyberKnife with its conformity may be a better option to treat irregular and large lesions. Now, not all targets are similar, so somewhere the target geometry also has a bearing on the kind of plan that gets developed by these different platforms. Most of the platforms which I mentioned, like Gamma Knife and Zap, they have a isocentric method of treating a target, whereas with the CyberKnife, you have the possibility of doing a non-isocentric kind of treatment, which provides a very elegant dose painting kind of dose sculpting kind of dose distribution inside the target, which is also a reflection of the larger number of angles that are available to us, for example, in CyberKnife compared to Gamma Knife. Now, there are very evident differences as far as the workflow is also concerned, in the sense that a frame-based radiosurgery would essentially everything would have to be done on the same day, whereas a frameless workflow is probably more comfortable for the patient, not only in being painless and less possibility of needing sedation, but also that the imaging and the treatment delivery days can be separate and can be scheduled according to the patient's convenience. So frameless workflow is ideal for multiple sessions, and retreatment whenever the occasion arises is very, very simple because the patient does not have an aversion to putting on a frame again. Now, coming to the outcomes. So one of the recent studies from last year, it was a systematic review of metastases that were treated frame-based and frameless. And out of a large number of studies, eventually 5 studies were included in the review, in which 254 frame-based treatments and 221 mask-based treatments were done. And the findings were that there was actually no difference in the outcomes as far as local control at 3 months or 6 months. So the only randomized prospective trial was by Professor Reggie et al. In 2022 published. And as I said, there was no difference in the outcomes. Now, another of the 5 studies chosen, surprisingly, the study by Grimm et al. Showed, and this was also a prospective, though non-randomized trial or a study, which showed a worse local control with the frame-based techniques. This may possibly be because the mean number of lesions between the frame-based and the frame-based and the frameless groups were different. So this study basically, what we would take it to mean is that there is clearly no outcome difference in terms of the local control or the adverse radiation effects between frame-based and frameless radiosurgery for metastasis. This is also evident from a number of other studies which have been done. For example, another study in 2019, and as I said, the study 9005 trial by Shaw uh, showed similar local control regardless of the platform that was chosen. Now, coming to acoustic schwannoma, again, a review by meta-analysis by Guadix, which showed 39 studies and comparable outcomes between gamma knife and LINAC radiosurgery. A CyberKnife meta-analysis published in 2017, 800 patients. So the tumor control rate and the hearing preservation rates very, very similar to the gamma knife literature. Now, I remember in 2018, there was a Congress of Neurological Surgeons task force which looked at the outcomes of radiosurgery. And in fact, they were also not able to find any differences based on frame-based or frameless. Having said that, I do think overall gamma knife enjoys a dosimetric and a long-term evidence advantage. But honestly, I think the outcomes depend more on the quality of the plan, the cochlear dose, and I think the experience of the person who is treating the patient rather than the platform itself. So again, similar studies which show that the 10-year tumor control, which is 93 to 97%, is independent of the platform that we use. And on the right is one of my gamma knife cases from several years ago. 1 year after 12 gray margin dose, you can see an excellent response. Now, meningiomas, again, the same review showed comparable outcomes between the gamma knife and LINAC radiosurgery. But having said that, the CyberKnife and LINAC score in terms of treating larger lesions, especially the perioptic lesions, and in multi-session indications. And again, having said that, gamma knife has a clear dosimetric and long-term evidence advantage favoring it. So I would just say that it seems to be another non-inferiority situation, but classic frame-based gamma knife for example, would not be possible for all meningiomas, even all small meningiomas. So the case in point is one of my patients, which I've shown here, a recurrent clinoidal meningiomas, small volume, but here the problem was the tumor was wrapping around 270 degrees of the left optic nerve. What we chose to do is a 5-session treatment, and we were able to develop a very elegant plan. And after 3.5 years of follow-up, this patient had a stable visual acuity on the left side and stable tumor size at 3.5 years follow-up. So this was an example to show that for perioptic lesions, if you do a multi-session frameless treatment, it is something which can work very well. Now, trigeminal neuralgia, the commonest functional indication, you have studies published which show a dosimetric comparison between the Gamma Knife and CyberKnife plans, or even for LINAC. And the CyberKnife could reproduce Gamma Knife dose distributions. But of course, the Gamma Knife has a steeper fall off and a more superior brainstem sparing compared to the CyberKnife and the LINAC. Now, another review in 2018 by Tuliasker from Switzerland showed initial pain relief scores were very, very similar. And if you look at the recent series, practically there is no difference. But of course, the Gamma Knife evidence base is larger, and there is a larger patient cohort evidence available in terms of the Gamma Knife. So in the present day, I would say there is a modest difference, if any, between frame-based Gamma Knife radiosurgery for trigeminal. And on the right side is one of my Gamma Knife plans for a left-sided trigeminal neuralgia. And this is one of my CyberKnife plans for a left-sided trigeminal neuralgia. And you can see that even in the CyberKnife, you have a very, very elegant sparing of the brainstem. The bright blue line is the 12 gray line, and you can see that it is nicely coming away from the brainstem, although at the point dose was something like 13.8 grays, which is very well tolerated and well within the recommended guidelines. So this patient had an excellent response at 1 month and was BNI grade 1 at 3 months onwards. This is an example of a LINAC radiosurgery for trigeminal. This is a treatment done by my friend and colleague, Dr. Shankar, who has used 7 non-coplanar arcs to achieve a very elegant dose distribution for a right-sided trigeminal neuralgia. Now, AVMs, we have a paper which shows, again, very, very comparable obliteration rates above an 18 gray margin dose. But Gamma Knife scores in the steeper response curve if you choose a margin dose which is below 18 grays. Gamma Knife is distinctly better for small lesions located in critical areas like brainstem and the basal ganglia. I think there is hardly any question about that. But CyberKnife and LINAC may be better for larger lesions or where fractionation is required. And you have now very interesting fractionation 2-session and 3-session literature coming out of larger AVMs, which cannot be treated in a single session. Now, this is a single institution analysis comparison between frame-based and frameless SRS in the same institution, and they found no difference. But this is, of course, a retrospective single institution study. But this is also supportive of the general evidence that there is not much of difference between frame-based and frameless radiosurgery for AVMs. So this is one of my CyberKnife radiosurgery plans for a pre-embolized AVM. And on the right is the vaso-CT, which we use for pre-embolized AVM, which tells us very nicely the patent part of the AVM. And in this particular case, the V12 was 4 cc's, and this was roughly, I think, an 8 centimeter AVM, and 16 grays in 1 session, 48 minutes on the couch. And you have this at 37 months post. If you see the bottom row of the images, the embolization material is visible, but there is no patent AVM visible after 3 years after CyberKnife. One of my Gamma Knife plans for a left-sided compact AVM treated with 20 grays in a single session. I think we published this several years ago. I'm forgetting where. Now, there are clear indications for frame-based radiosurgery, and these are indications where one would really like to have frame-based stereotactic localization of the target. And these are really targets which you cannot see with the naked eye. And any situation in which you are needing to treat a very small volume with a very high dose, and in certain critical locations where the sharper gradient becomes very, very useful. So the typical indications is, of course, radiosurgical lesioning, such as VIM thalamotomy or capsulotomy. Brainstem metastasis, I think, is also an indication where Gamma Knife would kind of have an edge. Brainstem and central AVMs, which are small in size, and other small AVMs in critical locations, because we do know that for AVMs, we have to deliver a high dose. Now, in certain situations, frameless radiosurgery may be the better option if you have to treat larger volumes, and if you have perioptic lesions or lesions close to very radiation sensitive structures. And I've shown you example of a meningioma, which fits into this bucket. Now, postoperative METS cavity radiosurgery is something which is much better done frameless, because at times you may be treating large cavities. And also literature supports that fractionation may give you better outcomes, because you have to treat these with a 2 or a 4 millimeter margin. Frameless is obviously also better when you have very elderly patients or very young patients for whom the frame would actually need full anesthesia. For example, patients who are extremely claustrophobic, who are not accepting frame applications unless it is in complete anesthesia. This is an example of a patient. On the top right, you see this metastasis, which was symptomatic, and we resected this. 3 weeks later, we found another enhancing lesion in ahead of this. And what we did is, in the same 3-session paradigm, we were able to treat the cavity and the new lesion. And on the left side bottom, you have the 2 years post CyberKnife result. Now, what are the key learnings from sort of comparing frame-based and frameless? So I would like to offer a couple of perspectives which are very sort of important to keep in mind. One is that just the platform being a frame-based or a frameless is not the final determinant of the accuracy of delivery. It is actually a whole set of steps which start with the imaging. And really, imaging is such an integral part of radiosurgery that it would not be a tall statement to say that the quality of imaging determines the quality of radiosurgery. Now, each of these factors which I've labeled out here can be responsible for a greater than 1 error contribution towards the total system error by itself. And this points to the importance of the man behind the machine and not just the machine itself. Another very large source of variation is contouring. So these and several other articles attest to the huge variation between different physicians who would contour a particular target. And this is, I think, very, very relevant, especially for AVMs, in which I think no two neurosurgeons would out AVM target. So a very helpful thing to avoid these kind of errors is to have contouring guidelines. For example, these exist for brain cavity radiosurgery. These exist for spinal metastasis. Now, the dose gradient, one of the things to keep in mind is the dose gradient of a single beam or a single shot is a property of the collimator, but when you come to a plan which consists of several shots or beams which are together creating the dose distribution, the dose gradient of a particular plan may be something different entirely. And that is why we need gradient index and other such indices which tell us the quality of a plan, and we do not blindly go just by knowing the kind of penumbra which exists for a particular collimator. A high quality plan depends on human factors. For example, the person who is doing the plan. Now, from the same benchmark study which I showed earlier, all these indices are actually arrived at by very, very experienced radiosurgeons who are doing the planning for a particular indication. And this is based on the foundation of what the platform can do technically. But really, the quality of the plan also depends on the kind of constraints that are placed on the planning software, and you have different iterations and different plans that are analyzed before you deliver the final one. And there is always a certain kind of fine tuning and adjustment which happens given a typical or a particular patient scenario. To give you a small example, if I am treating a patients with 10 metastases, I think what would also be more important for me is to optimize the treatment time rather than just the conformity index. So radiosurgery outcomes, I think, depends on a nice balance and a nice mix of the human expertise, which acts in conjunction with several technical attributes of a radiosurgery procedure, which I mentioned in this slide. And selecting the correct patient, of course, is primarily the contribution of the radiosurgeon or the neurosurgeon who is doing this. Now, there are more than one correct methods available. So as I said in the review of indications and also in a review of the accuracy, I think there is a lot of comparability and parity in terms of the accuracy and outcomes between the modern day frame-based and frameless platforms that are available, and the gap is continuously closing. The case in point being, if you compare the 2016 benchmarking study by Paddock versus the recent 2022 benchmarking study. I think these different frame-based and frameless solutions have to be looked at just as different engineering solutions and which are trying to achieve the same end result. So I would be very wary of the vendor pitch when the new system gets launched and it is quoted as the best system with the lowest sub-millimeter accuracy. Each platform and strategy has its own advantages. For example, we've seen that there is an inherent trade-off between having the highest gradient versus having the highest conformity. Obviously, one does need to factor in the comfort of the patient, the feasibility of repeat treatments. So the important thing is to use the correct tool. So for something like this, for example, doing a VIM thalamotomy, I would say definitely it has to be the gamma knife with the frame on that can give us this kind of elegant result. And each clinical scenario also has its own particular nuances. So to give you a counter example, we've been talking about high conformity. Now, high conformity is not always desirable. Now, look at the study from 2006, in which one of the predictive factors for failure for cavity radiosurgery was a conformal plan. And what we need to do in cavity radiosurgery is to add a 2 millimeter margin, and that is what will give us good outcomes. Another counterexample in which if we try to do a frame-based single session radiosurgery, and for a slightly larger volume, if you compromise the dose, then the local control can be inferior to using 3 to 5 sessions. So this is something which was shown very nicely in the Lancet Oncology study by Brown et al. And therefore, a single session frame-based treatment is not the best solution for every situation. So important is to know the platform that we are using. So if you compare the Gamma knife, which is the traditional frame-based versus the CyberKnife and the Linac and the Zap, I think each of them has their own advantages and disadvantages. And they are, at the end of the day, very, very comparable, but you have to differentiate between the key strengths and the key limitations of these different platforms. For example, Gamma Knife and Zap are head only. They are customized platforms which are designed for treating the intracranial compartment, whereas the Linux and the CyberKnife are more versatile. They can treat the spine and other organs in the body as well. Gamma Knife, for example, has a slight one should know that once the dose rate reduces as the cobalt source decays, it can have a modest impact on the outcomes of patients, both for trigeminal neuralgia. And I believe there is a paper also which shows this in meningiomas. I think no radiosurgery presentation can be complete without this quote of a fool with a tool. And I think the basics are something which are inviolable. And one of the things which you really have to know is that what dose are you using for a particular indication? So this is one of the favorite slides I like to show of a patient who came to me with a 5-session Linac treatment done elsewhere, and 1 year after after radiosurgery in 5 sessions, 35 gray. Look at what happened to the brainstem, and this patient actually needed bevacizumab treatment to sort of cure his radiation necrosis. So in the current scenario, I think we are looking at what is called as a hybrid precision with patient comfort being factored in. So this is evident from the Gamma Knife icon, which allows frame-based as well as frameless treatment. And you will have a flurry of things coming out very soon. For example, AI-driven positioning correction, surface-guided adaptive radiosurgery, flash radiosurgery, which uses very high doses, guided radiosurgery, akin to what is being done with the MRI Linac, and much improved motion prediction algorithms, which may not be very important for intracranial work, but certainly for elsewhere in the body. So in essence, I would like to say that the frame-based and frameless platforms and strategy is very similar in its accuracy and patient outcomes. We just need to know the inherent advantages and limitations. And the two statements which I will make here is to choose well what you need, both in terms of the platform, the kind of plan that you need, the kind of dose that you need, the fractions that you need, and the other options that may exist for a patient outside of radiosurgery. Also, to use well what you have. And essentially, I think the bottom line of radiosurgery, because it involves a lot of critical steps, is to have very, very strong teamwork. So I would like to acknowledge my team, in which we have radiation oncologists, we have physicists, technologists, nurses, and I would especially like to thank Dr. Shankar from Chennai, who's a good friend and a colleague, for his help with some slides and the materials. Thank you.
Thank you so much. It was a perfect presentation about frame-based and frameless radiosurgery. We all need these kind of presentations. Thank you.
Thank you.
Thank you, Aditya sir. As I know you personally, you have been able to generate safe and effective radiosurgery across the machines over the decades. So, and you are the perfect person to answer this query. Means, as you have transitioned from the frame-based to the frameless one, do you believe that debate between this frame-based and frameless is truly about accuracy, or has it now become more about the workflow and the patient experience as you show these comparable benchmarking studies? So are we heading towards more on the patient's safety, patient's comfort, the physician's comfort rather than the accuracy part? As you say that, okay, still the gamma knife is the best, but the gap is getting slower, gap is
Yes,
getting nearer.
I think the gap is actually getting very, very narrow. And that is I think the prime example is the gamma knife icon. Now, this is a technology which started as a purely frame-based treatment philosophy, and now to accommodate the patient comfort, and also not only patient comfort, I think it is basically so that multi-session treatments can be safely delivered. So I think we are looking at one, patient comfort, but also the multi-session treatments, which are becoming more and more frequent as we treat more and more complex lesions. I think these are the two main reasons for the frameless philosophy to gain wider and wider acceptance.
This question means I would like a comment from Professor Selzuk, because he does a lot of fractionated work and he is still practicing on gamma knife. He transitioned from perfection to the icon. So in his current practice, he treats close to around 800 to 1,000 patients per year. How many are actually still frame based and how many are frameless in his practice?
I began to use model icon than Esprit in 10 years ago. So in these years, I can say that roughly 1/4 of the patients are with mask, and 3/4 of the patients are still using. I do treat them with frame, and only a few patients I have treated them for a single session treatment with mask. I choose frame instead of mask. Dr. Gupta, you worked with the frame-based systems for many, many years. Then you are working with frameless systems for many years. In my opinion, or in my feeling, I feel myself more safe when I use frame instead of frameless mask-based treatment. What is your feeling about it? What do you think?
I think being a neurosurgeon and also being someone who does other parts of functional neurosurgery, so I have a natural proclivity and fondness for using the frame. But having said that, I have been very pleasantly surprised by results with the single session treatments on now using the CyberKnife. And I do not feel that I have kind of seen situations in which I thought it was a compromise. In the larger lesions, for me, doing a multi-session treatment is just so easy. It takes all of 10 minutes to change the plan from a single session to a 3-session plan. If I have a concern that this 10 cubic centimeter target is better treated in 3 sessions, then I can very easily do that and achieve excellent outcomes.
Dr. Aditya, this question regarding the fractionation, probably this has been diluted by the frameless radiosurgery by gamma knife as well. So that dogma that the frame should not be used, that can be understood. But now, since these machines are doing the fractionation, there are attempts when people are trying to do the conventional fractionation schemes of more than 20 sessions, 30 sessions with the gamma knife, as Sunnybrook has been trying it. So what is your opinion about these hyperfractionation sort of a thing with the frameless radiosurgery with the current versions of the gamma knife? Probably they
On
give some radiobiological advantage with their sharp dose fall off, like if you're treating a craniopharyngioma or a brainstem ependymoma?
So honestly, I have been very traditional with my approach, and I have not done any treatment that is more than 5 sessions using the cyberknife. And I think I would rather go towards IGRT or IMRT if I had to do more than 5 sessions. But I think you have a point that maybe in the future we will get some literature to support a hyperfractionation schedule. It's just that I'm not comfortable myself in doing those kind of hyperfractionated treatments.
Professor Selzuk, you were asking some question.
For the large tumors, of course, or for the large lesions or the lesions which is very close to organ at risk, optic nerve, etc., it's very nice to use hypofractionated treatment. We do use it in our center also. In the past, of course, to use frame-based system and to do a hypofractionated treatment, it was it's a kind of very kind of torture to the patient, I think that. But with the mask system, it is easier today. So can I ask you a different question? When we use gamma knife, we mostly use in most of the patients, we use 50% isodose line. And for example, if this is a meningioma, we do give 5 times 4 gray or 5 times 5 gray. But when you use cyberknife, you use mostly 80% or maybe more than 80% of isodose line, and you use same doses, for example, 5 times 5 gray or 5 times 4 gray. Do you think that there is an radiobiologic difference between these hypofractionation systems applications?
I think the internal dose heterogeneity with the gamma knife is much higher than that of the cyber knife or the Linac. Having said that, many times I find myself using, for example, the 70% isodose rather than the 80. And I think it's just a question of how these different beams interact with each other and what kind of a trade-off you can have between the high dose spillage and the low dose spillage. So if you use a higher isodose, I think the low dose spillage is going to be even higher.
And the other thing I would like to give some information about, nowadays we changed the workflow of gamma knife in the last 10 years. We don't apply frame for the pre-treatment MR images or CT images. We do get frameless MR and CT. We do the plan. And like you said, that if we think that this tumor will be nice to treat with hypofractionation, we can apply a mask. Or if we think that this is a frame-based treatment, nice for the patient, we can apply a frame and get COMBIM CT and see the stereotactic image. So the workflow is changing in the last years. So this is also another advantage of gamma knife radiosurgery, I think.
I think that is a very elegant advantage of the gamma knife icon, in the sense that you could do a multi-session treatment with the frame for the first session. For the remaining 4 sessions, you could use a mask. You could do a completely frameless treatment if you wanted. So all these combinations are possible. And as you rightly said, it permits you to not to have to make that decision up front. I think that is a very valuable advantage of this philosophy, which I call as the hybrid precision. You know, it combines best of both the worlds.
Thank you so much.
Dr. Aditya, as these Jan Pedic also had some studies on the extracranial dose distribution of the radiation. Then he put some markers over the thyroid, uterus, and then the same plan was evaluated on different platforms. And then he tried to extrapolate the chances of the radiation-induced carcinogenesis. And that were found minimum with gamma knife, maximum with the Linux-based machines. So, what's your practical experience over it?
See, practical experience is that no doubt if you have a system like ZAP or Gamma Knife, which is basically designed to treat the intracranial volume, then the body doses are definitely going to be much lower. Having said that, what is happening, for example, as far as the cyberknife goes, is that with some recent algorithms, for example, our current cyberknife has the Volo optimization algorithm. Now, with that, the body doses have been reduced by almost 50%. And I would say for most of the intracranial treatments that I do, the body dose would be less than what one would expose the patient to if one does a CT scan of that part of the body. So it's below the level of an exposure that would be had you done a CT of the chest or the abdomen. So I think the body doses have come down drastically. But yes, I think the point here is that you can't actually compare a full body radiosurgery system with a system which is designed only to treat the head.
Again, coming to these comparative platforms, like you quoted that study by Tuleska. So, radiosurgery is about safety. It's also about its complication profile and the side effects. So, in the same, they say that compared to this frame-based system with the Gamma knife, the chances of trigeminal sensory neuropathies are significantly higher with cyberknife and other Linux-based techniques because probably a longer length is being exposed. So that I find as a trade-off because the patient is getting relief, but also getting a complication in return.
Hmm. I think that is something also where the gap is becoming bridged very, very quickly. Because as we get wiser about which part of the nerve and how much length of the nerve we are irradiating, and also very important is the length of the nerve and the size of the cistern, I think you will find the outcomes being very, very similar. Now, having said that, you know that there are certain institutions using the gamma knife which are still targeting the root entry zone. There are institutions which are targeting anywhere in between where the 20% isodose line touches the brainstem.
Yeah.
So you have all kinds of these targeting happening. In the midst of that, I think the outcomes would be very, very close together if you have enough expertise and if you are able to have your platform perform at its best.
I totally agree with you because that study which was published in 2018, and it's now time for a subsequent study because over the course of years, these technologies and their providers have become experienced and more nuanced in this technique. So probably
Right.
this gap is also getting narrower. Uh, as far as the single brain metastasis is concerned, the results are practically the same. But once you go with the uh, once you look at the planning with the multiple brain metastasis, there is a significant crosstalk between the radiation. And this
Right.
actually increases significantly high in the Linux-based machines with the frameless ones, so that a large area of the brain practically gets exposed. So if the patient is having some 10 or 12 metastasis and you are treating with the Linux-based machine, it looks like somebody has been treated with a WBRT with the kind of the dose fall off.
True. True. That I agree.
So
In multiple brain metastasis, I think the gamma knife superior dose gradient definitely has an edge because now people are pushing the envelope and treating 10 and 15 and 20 metastases, which never used to be the case.
yeah, so that might be one indication. So machines are getting better, and still, as you told, that probably it's the more important is the clinical judgment, the way you contour, you plan, because there are something which is related to the engineering, and rest a lot of things are related to your clinical practice, your philosophy of defining the target, putting the shots, and to making a plan. So that probably is going to make much more difference other than the technology itself.
Absolutely. I'm completely sort of sold onto that part, and especially in India, we don't have the luxury of everybody getting a gamma knife to work on. It is only institutions which need a dedicated brain-only system, and that can justify the volumes of having such a system, and also the cost that comes every 6 or 7 years with for the sources and so on. So I think the practical thing for, let's say, a neurosurgeon who wishes to start doing radiosurgery, the overwhelming chances are that that person would have to work on probably on a Linac or a CyberKnife or a Zap.
Yeah, I totally agree with you, because in our scenario, the issue is more about the availability and the access to the patients and the physicians both to get trained and to treat the patients. So that is a practical question.
Yeah, absolutely.
Any final word by Dr. Salzuk? Any comment?
Thank you so much. It was a very nice discussion about the frame-based and frameless systems. Thank you so much, Dr. Gupta.
No, and it was a huge pleasure for me. And thank you, Maljun, and thank you, Dr. Selsuk, for this opportunity. And it was very, very nice learning experience, and interesting to have this discussion with both of you.
Thank you so much, sir. Thank you,
you.
attendees, for attending this webinar, and to all our viewers. This would be telecasted on the WFNS YouTube channel, so you can have the recording whenever, if you couldn't attend it in the real time. Thank you again for attending it. Have a
Thank you.
Bye-bye,
good
everyone.
night,
you.
Bye-bye.
and
Bye.
see you in ISRS in Sydney.
Yeah.
Bye-bye.
Bye. Thank you so much. Bye.
Thank you.